This is a presentation describing common elbow, wrist, and hand injections performed by ultrasound guidance. There are many more than are described here in this presentation, but here are a few of the basics. First, we'll start with the lateral elbow at the lateral epicondyle. And first thing that you can see is to mark your landmarks, it's recommended that you find that lateral epicondyle and then place the transducer in front of it and point the rest of the transducer down the common extensor tendons towards the wrist, and you'll find that lines your image up quite nicely. Landmarks here, obviously the lateral epicondyle and the radial head. Once you get your image, if you're a little confused which is which, if the proximal and distal doesn't give it away, pronation and supination will rotate the radial head. Your patients also really enjoy seeing the ultrasound image move. So I would recommend anytime you can make something move in the image to make it move. And in this case, on the next couple of slides, you'll see I would recommend that you go ahead and pronate and supinate, and that would revolve the radial head in the image. What we're going to be looking at is the extensor tendon as it inserts here to the lateral epicondyle. Underneath is a nice joint capsule for a joint injection out of plane. But for today, we're going to talk about just peppering the outer surface of this tendon with something common like a corticosteroid. Here's your imaging. You can see the finger is placed behind the epicondyle and the transducer is pointed nicely down the extensor tendons of the forearm. You can also use your thumb and pivot the transducer back and forth, planting the proximal side of the transducer at the lateral epicondyle if you don't get the image that is seen here. So here's our lateral epicondyle, here's our radial head, and if they turn the wrist up and down, pronate and supinate, the radial head will actually move in the image and the lateral epicondyle will remain stationary. Our target of interest here is the common extensor tendon. We don't want to inject the tendon itself, as it may cause something like cavitation of the tendon fibers and create the tendon elasticity to be brittle instead of strong. If your goal is to inject other things rather than a corticosteroid that are more targeting the tendon, this is obviously a very easy approach to do and land the needle directly within the tendon. Here's an example of the direction, and you can see how the transducer is being held with the face of the transducer here open, allowing the injection side to allow the needle to be there. What I'm saying is you don't want to cup your hand entirely around the transducer, or you're really going to lose your ability to guide the needle with a direct visualization under the transducer. So let's play this video. You'll see the needle coming in from right to left here, distal to proximal. And in this case, just landing the needle above the tendon sheath here, this undersurface, which is just a fascia of the common extensor tendon. So as this video loops, you'll just see that the needle does not advance any further, and if we were to keep playing the video, I think the injectate would spread on top and down the common extensor tendon. The next one is cubital tunnel for ulnar nerve mononeuropathy. So basically, any of these symptoms that you might want to alleviate related to the ulnar nerve pathology, this might be an approach that you want to try. First, let's point out the anatomy. We have the olecranon process of the ulna. This is the triceps tendon, which we'll talk about briefly here in a moment. And then here's the medial epicondyle of the humerus. Now, the reason the medial epicondyle of the humerus is so important is that the ulnar nerve is going to wrap very closely to the medial epicondyle. In this particular illustration, there appears to be maybe a deviation of that tract, but the ulnar nerve actually follows this inner border of the medial epicondyle of the humerus, not the ulna. Here we have the ulnar nerve sitting on the medial epicondyle of the humerus. Now we have the olecranon process of the ulna. The medial head of the triceps tendon actually attaches here, and this is why it's so important that when the patient does more flexion, you'll actually have the medial head of the triceps pull through this cubital tunnel. The reason that's a common issue is that that medial head of the triceps will force the ulnar nerve up and over the medial epicondyle of the humerus, and that could be one common cause of ulnar neuropathy. Now, if you see this asymptomatically, this dislocation or this perching of the ulnar nerve, check the opposite side, because we commonly find that the subluxing ulnar nerves are bilateral, especially in patients where they're not symptomatic. You just happen to find it. You also want to float a heavy amount of gel here between the transducer and the medial epicondyle, so that you're not forcing the nerve to stay down into the groove. Basically, if you use a lot of gel as a standoff and let up transducer pressure, the nerve may actually start to transpose itself on top of the medial epicondyle without any help. So that's also a way to tell if the ulnar nerve is just moving around excessively. Now, if you see inflammation around the nerve, it's going to be good to land a needle near it and see if you can alleviate the patient's symptoms. And that's what we're going to do here. We're actually bringing the needle across the surface of the olecranon this way, over that medial head of the triceps, and then the goal would be to land the needle under the nerve first, and then land the needle on top of the nerve second. So the reason I say go under the nerve first is that if you are to inject the nerve or inject on top of the nerve, and there's any air in your needle or any steroid that might reflect a scattering artifact, you don't want the artifact to scatter down on top of your target. So if the needle were to land here and you inject, and there's any air in your needle, you would actually just disrupt all of your imaging that takes place underneath the needle, and you would not be able to see the ulnar nerve anymore. So just as a rule of thumb when doing injections, if you're trying to take multiple approaches at one target, to always start deeper and work your way superficially, and you won't actually cloud artifact on top of your target that way. The next one would be an intra-articular elbow injection. This is done a couple of different ways. The first way, which I briefly alluded to on the beginning of the presentation, was to go out of plane right through that common extensor tendon portal into the radiocapitellar joint, which is totally acceptable. You just don't see the needle as clearly as you might see in the longitudinal approach that we're about to see posteriorly. So here we're going to look at a couple of different windows, but this one has the example to be shown where you land the needle just underneath that olecranon process of the ulna and above the posterior trochlear surface of the humerus. This is where you're going to find that fat pad sign. So here's the fat pad that you would look for on a radiograph to be lifted. So here's the actual effusion pooling place here on the posterior trochlea of the humerus capitulum. So what we look for is an effusion to pool down here and distend the fat pad, but since the effusion is leaking out of this particular joint right here, our only goal is going to be to land the needle right here into the joint and then shoot. There's no need to run the needle down underneath this fat pad. This fat pad is extremely vascular, and you'll notice if you throw your color on this little triangle, you're going to get a lot of color signal in the form of arteries and veins, and it's just one way to reduce the risk of even a hematoma kind of bleeding into this recess. So let's go over these other landmarks for the radiocapitellar joint. We also talked about the common extensor tendon. Here's a distended joint capsule lifting up that common extensor tendon just a little bit. I will say variations in flexion and extension of the elbow might make this recess actually perch itself out and make it an easier target. Let's go for the posterior window here, where you can see the needle. We've slid the transducer just slightly lateral to the triceps tendon to make an easier window so that you're not pushing your needle through tendon. If you push your needle through tendon, it's pretty tough. Your patient's going to feel a very dense pop once you make it through the tendon, and it may alarm your patient. And you don't want to go medial to the triceps, because the ulnar nerve will start to border some of the anatomy that you're trying to traverse. So it's recommended to place the transducer in the longitudinal plane of the triceps tendon and then move the transducer laterally to get away from the triceps tendon, more into the muscle belly, so that we end up with an injection like this here. And then when you do inject, you don't want to see a localized filling or ballooning. What you want to see is injectate spreading down that posterior trochlear recess right here. So you can see this ballooning, this fat pad lifting. You're causing and a fusion, but this time with your own medication. Now out of plane, radiocapitellar joint. On all the machines out there, you can actually press the M mode button, and what you're going to see is this line come down, and you'll see that that would be a nice guide to say where you want to land your needle out of plane. And here in this case, we've landed the needle between the radial head and the lateral epicondyle of the humerus. So you can see the needle is just a bright dot. And that's why some people don't prefer this injection orientation, because you don't see the nice long shaft of the needle. You only see the little dot, that little hyperechoic metallic artifact. And so when you do inject, you have to really fan the transducer back and forth and make sure that you're not exterior to the joint. So there is a constant back and forth with the transducer plane to make sure that your needle has not exited the joint at any time during the procedure. What I'm saying is, if we were to take this slice here across this needle, and if we're only seeing a cross section of the needle, you can accidentally be taking a cross section through the mid portion of the needle, or the distal third or quarter of the needle, and instead of the needle tip. So you're constantly needing to fan back and forth to find the needle tip, and that's a big deal when you want to know exactly where your injectate's going to spread. The wrist injections, we're only going to cover a few, but the ones that are most common we're going to see are for the dorsal recesses, and these are for synovitis. We see a lot of degenerated joint disease and gout. So especially in the rheumatology field, but you'll see this in sports medicine when people sprain their wrist and they get a lot of inflammation in and around the scapholunate ligament. We end up seeing a lot of acute synovitis in this area here. So basically what we're going to be doing is setting the transducer right here across this plane, and we're going to see this joint capsule as a fold and as another fold. So we have the radius, the lunate, and then the capitate. And between the radius and the lunate, there's a little joint fold here, and that represents one articulation between the radius and the lunate. And then there's another joint articulation between the lunate and the capitate, represented here by another fold. And then there's a radioscaphoid articulation, which is only an extension of that radiolunate capsule and also represents the same access point. So you can find the inflammation to be pooling up bigger or smaller on either side. It can be mid-sagittal to the wrist, or it can be more on the radial side. But I sweep the transducer from mid-sagittal all the way over here to the scaphoid side routinely, just to check for any larger pockets of inflammation that I might have missed. And joint effusions collect here as well. Here are the capsules represented in the diagram. We are mid-sagittal at this point. We can see the radius, lunate, and the capitate very nicely. We have the that joint capsule here represented in blue, and these are just folds in the joint capsule here. So they're pretty easy to see, and our target here is simply to land the needle within that joint capsule. Here we've opted to go over to the radioscaphoid side and go out of plane, so you can see the needle's going right underneath that line. And this would be a good case to go ahead and place your M mode down if you weren't super confident where your needle was going to land. But here we can see the out of plane needle. It's going to poke through the superficial connective tissue. Then hopefully we start to see a little bright dot down here near the articular cartilage. This thin black line here on top of the scaphoid, that's the articular hyaline cartilage, and that is the way to truly see if your needle is near enough to the joint capsule to go ahead and give a test injection. So what I want to see is that white dot get as near to that articular hyaline cartilage as you can. Give it a test push with the plunger, and if the injectate follows the cartilage up and down, you're in good shape. First, CMC joint, also very common and commonly done under fluoroscopy. Hand surgeons typically will grab a fluoroscope in the office. Pain management people often get referred these, but now they can be done under ultrasound quite easily, same indications. Here our landmarks are going to be the first metacarpal and the trapezium. We're going to place the transducer almost laying down with the table. So if the hand was laying flat on a table, your transducer orientation is almost such that the transducer is going to lay down on the table. You're kind of taking a perfectly coronal shot across the wrist and the base of the first metacarpal. So we have the base of the first metacarpal, trapezium, and then the scaphoid starts to peek itself into the image here. But we're mostly focused here on this joint. Another way to make that joint really show is to kind of squeeze the patient's hand and push down on that proximal first metacarpal, and you'll get the joint to open up dynamically. Here we're going to show two different injection planes. So we have what's called out of plane and in plane, as we described earlier. And basically the needle's going to come in plane this way. We're going from distal to proximal. The way that we can tell that which side's distal and which side's proximal, here's the radius, and here's the scaphoid, kind of the neck of the scaphoid. We're slightly volar in this rather than dorsal for a few reasons. The more dorsal you go and proximally, you're going to hit a little bit more branches of the radial artery. So with ultrasound, you have the ability to go touch more volar on the CMC joint where you normally wouldn't go blind, because you just can't palpate the joint very well because of the thenar eminence. These muscle fibers over here typically get in the way of doing a blind injection a little bit more volar. But I will say that under ultrasound guidance, it's quite nice to go slightly more volar and see the needle have a little bit of tissue to go through before it hits the joint. That would help you be a little bit more accurate. So let's start with the in plane, and the out of plane is on the bottom. So in plane, here we are just barely dropping the needle right there on top of the base of the first metacarpal. There we saw the injectate actually follow down into the joint. There is a natural vacuum to the joint, so as you inject, typically the injectate really does follow that natural vacuum. Here we are out of plane. A little more difficult to see, but we're just looking for that bright dot. We have our M mode button activated here, or a center line on your either Edge 2 ultrasound machine or export. But here what we're trying to establish is the tissue movement, and then the bright hyperechoic dot. And then there we drop the needle down. Same thing applies. Go ahead and inject, and if you see that injectate start to follow that natural vacuum, you're in the joint. If you see it start to balloon up into that thenar eminence, you have missed the joint and you need to redirect and probably steepen your angle more acutely the syringe towards the transducer handle. So tighten that angle and start heading a little bit more straight down to hit the joint if you're starting to see your needle up here in the thenars. Next is the carpal tunnel, and the injection indications are median nerve mononeuropathy. There's also a few other indications that you want to look for diagnostically, and you want to check that out in the wrist diagnostic presentation, which are looking for maybe postoperative surgical metal, ganglion cyst, tenosynovitis, other reasons to have carpal tunnel. But in this case, we're just going to target strictly how to visualize the median nerve for an injection. The median nerve here, the landmark that you want to find is the pisiform. And then once you have the transducer over one surface of the pisiform, fan the other side until you see the scaphoid. You're not quite in the carpal tunnel until you see the pisiform and the scaphoid. Here we have illustrated the scaphoid, as I mentioned below, and the pisiform bone. These represent the proximal carpal tunnel, which we can see here. The wrist crease, if you're just looking at the patient's palm and you see the wrist crease, the transducer would be placed just distal to the wrist crease in this case. Palpate the pisiform bone first. Place your transducer over the pisiform until you see this high superficial hyperechoic echo with a signature of bone casting a shadow. So I don't see anything underneath the bone, which is very nice to identify. So the reason this landmark is so important is that we have the pisiform here, we have the ulnar artery as illustrated down here, and between the ulnar artery and the pisiform is the ulnar nerve. It's been described that the ulnar artery is ulnar to the ulnar nerve. So think about that for a second. As you trace that up proximally into the forearm, the same rule applies if you're looking for the ulnar nerve relative to the ulnar artery. Identifying this as Guillen's canal. Okay, so the reason I'm pointing this out is so that you can identify the full extent of the transverse carpal ligament, or that flexor retinaculum of the carpal tunnel. So you can see this shadow here. This is anisotropy. So as the retinaculum goes parallel with the transducer surface, we see a nice bright hyperechoic flexor retinaculum, or transverse carpal ligament. As the transverse carpal ligament tends to dive, right here you start to see the angle dive away from the transducer. We can see the shadowing, which is represented by anisotropic artifact. This is outlining the carpal tunnel proper. And then here over the median nerve towards the radial side of the wrist, we also see this flexor retinaculum takes an acute dive, very sharp dive, between the flexor carpi radialis tendon here, exterior to the carpal tunnel, and flexor pollicis longus tendon here, which is within the carpal tunnel. So this dark area does not represent fluid. This is not a cyst. This is a perfectly anisotropic environment, meaning that all of these fibers are diving completely away from your transducer. You'll notice there's no shadow artifact here, and that's because this is just simply caused by anisotropy. This is not something that is casting a shadow. It's not a density. It's just a pure anisotropic environment, and the more dense these fibers are, the more they respond to anisotropy. So to identify the flexor tendon layers here, we've got the superficial or flexor tendons, the superficialis, which are the ones just below the median nerve, which is outlined here. Then we have the profundus layer here. So to identify those, just have the patient wiggle their fingers. And if you really want to tell the difference between the superficialis and the profundus layer, you can passively either flex just the tips of the fingers down by the DIP, or you can do a full flexion at the PIP to see the differences between the profundus and the superficialis layer. There is a nice bursa as illustrated here that traverses through the carpal tunnel, and obviously what we want to do is land our needle in what's called the safe zone, which is going to be on the ulnar side of this median nerve. You can also land it on the radial side, but it's not always recommended. Basically, when you get your ultrasound down, take a look and see which side you have more room for. But there are a couple of superficial nerves that are not described here in the presentation that tend to lie on the radial side more than the ulnar. So that's why this is called the safe zone, the ulnar side between the median nerve and Guyon's canal. There's a little pocket. You want to land your needle right here where the mouse cursor is. Two different approaches, medially and laterally, have been described in the literature to see your needle in its full length. You can also do the out-of-plane injection and just drop your needle right next to the nerve. That might have been too easy to show here, so what we're going to do is just show where to land your needle, going through, in this case, the radial side, right over the scaphoid. So what we're doing is we're going to land the needle underneath the nerve first, because what we want to do is avoid injecting on top of the nerve. If you inject on top of the nerve, that's going to shadow whatever you're injecting, whether it be steroid or whatever. Maybe you even have a little bit of air in the needle, which does happen quite often. It's going to cast a shadow down on your nerve, and you don't want to do that. So start deep to the nerve, back out, go side to the nerve, and then go on top of the nerve. And basically what we're going to do is what's called a hydrodissection, and that's landing this injectate. And you want the injectate, if possible, to completely circumferentially surround this nerve before you advance the needle anymore. But right there at the end of the video, we saw right there the injectate actually makes its way to the other side of the median nerve. At this point, what you'd want to do is back out and go on top of the nerve until you see the injectate completely surround and envelop the nerve. Flexor tendon sheath injections. We're going to focus on the MCP joint level, and specifically for the second digit. So we're going to look right here, proximal to the A2 pulley, and the anatomy that we're going to look at right here is where the flexor tendon makes its way into the A1 pulley anatomy, and then it exits the A2, and that's where you're going to find your ganglion cysts, also going to be described in the diagnostic hand and wrist presentation. So take a look at that one after you take a look at these. Here what we're going to do is set our transducer just mid-sagittal to the joint. It's in a longitudinal plane of the flexor tendon. We see the A1 pulley sitting right on top, represented by this dark shadow that you see on top of the flexor tendon. Now to evaluate this even better, if these margins are not super clear to you, do a slow passive flexion of the distal DIP joint. What's going to happen is this flexor tendon is just going to twitch back and forth underneath the pulley. If the superficial margin is not distinctly clear to you, which is which, I just would ask that you do a little heel and toe pressure on the transducer, and your goal there is going to be to passively move the subcutaneous fat over the pulley. So when you rock the transducer back and forth proximally and distally, apply that pressure distally and then proximally, what's going to happen is the fat itself is going to move back and forth on top of the pulley, and the pulley will remain stationary. So that's how you delineate and identify the margins of the inferior surface of the A1 pulley and the superficial margins of the A1 pulley. Here's an example of a flexor tendon sheath injection here, submitted by one of our physicians, Dan Malone, and he's going to land the needle just inside this lesion here. And when he does that, he's very cautious and make sure he does not approach any further. So once his needle has gone into that hypoechoic defect, is when he lands his injectate.